Hey, good evening, everyone. Tonight is not Sunday, October 3rd. That I must have pulled up my wrong PowerPoint. Just in case any of you were wondering, you are in the right place. It's Tuesday, October 19th, and I'm Debbie Hill-Bissell, and we are going to do case list review tonight. I doubt very much I need to go over this at all. What's the main thing you guys need to know? You need to know if for some reason you called in on a telephone because for some reason your mic and speakers weren't using or that's what you needed to do. If you click telephone, it'll give you a phone number, an access code, and a PIN. Most important thing is you're going to raise your hands in order to volunteer. And tonight we're going to be doing case lists. So what, again, in the interest of testing and when everybody tests, what I'd like to ask first is for the people who are testing next month, because we're getting closer and closer, actually it's less than 2 weeks now. So for anyone who's testing in November who would like an opportunity to do a case list and they have not been called on yet this month, please raise your hand and I'd love to be able to get to everyone. So let me just get out of the PowerPoint here. And let me get my case list pulled up so I've got those. So again, anyone who's testing next month and hasn't had an opportunity to go, let's do those ones first. All right, let's start with Brandy. Hi, Brandy.
Hello, can you hear me?
Yep, I can hear you just fine. So you're a generalist, are you?
I am.
Okay, and when is your test date?
It is November 4th, that Thursday.
Oh, okay. So I actually did a mock oral with somebody who she was like, no, I'm November 1st, 9 a.m. I'm the first of the first. And I'm like, yes, you are. So where are you?
I
Brought
emailed
up.
last week.
You emailed it when?
Last week?
Wow. Because these are Octobers that I pulled up. October 21. If you see something that I don't, because I put it in alphabetical order.
Bottom somewhere.
I don't see it. Well, then let me make up something. Do you have a case list that you'd like me to throw at you? I'm sorry, it's not here, so I don't know what else to do.
That's
Unless you've got your case list in front of you and you want to present a patient to me, and then I'll question you. I can do either one.
you can just come up with something. I think that's probably how the real exam is going to go anyway. So,
Okay, do you have a preference of which case list?
let's do office. I feel like that's the most broad, so it's a little more overwhelming.
Okay. All right. Let me do. You have a 52-year-old G3P0 or G3P2 who comes in. Her last menses. No, let's do this. She status posted TVH 6 years earlier for abnormal bleeding adenomyosis. She's now 48, excuse me, 52 with significant vasomotor symptoms, but she's also in for an annual exam. So she's 52, annual exam, had a hysterectomy for benign reasons, and is complaining of hot flashes. So let's start with the annual exam first. Tell me what sort of screening are you going to be doing for a 52-year-old?
Sure. So as far as routine screening, as long as her hysterectomy was for benign indications and she did not have a history of CIN2 or CIN3, I would no longer be worried about pap testing in this patient. I would make sure she were up to date on her mammogram, which should be done annually. And then I would make sure she had had a screening colonoscopy since the age of 45. If she had had that done, I would ask her how soon she had been recommended to repeat that to ensure she wasn't a 3 or a 5 year repeat.
Okay. She's 52. What about labs?
So labs, she should have a fasting lipid panel done at least every 5 years, I believe, and then she should also have a TSH. And those would be the routine ones. In her case, I would definitely do the TSH since she was also complaining her complaint of hot flashes. It's not always reliable, so it's not always elevated if a patient's going through a menopausal transition, but in this patient, it would be a little bit harder to figure out since she wouldn't have the bleeding symptoms to accompany her menopausal transition.
Okay, you know what? For some weird reason, you cut out on me for a little bit. So I know I heard you say you would do the TSH, and then I'm guessing from what I heard in addition, the rest of it, that you said because she's had a hysterectomy, you would do an FSH just because.
Yeah, I said that you could
Meaning
get
because
one.
she did.
Sorry, go ahead.
No, go ahead. So you were saying, tell me what you said.
Oh, I said that you could get an FSH, but even if it were not elevated in the postmenopausal range, that would not rule out menopausal transition as the source of her symptoms. But it would just be
Okay.
a little bit
All right,
harder
good.
since she didn't have the bleeding changes, since she didn't have her uterus anymore.
Is there anything else that we should screen for at annual exams?
In terms of laboratory testing,
I'm just saying, just screening in general. What does ACOG recommend we do?
so I would also just screen for domestic violence. I would make sure she were doing basic, safety things like wearing her seatbelt and wearing sunscreen in the sun, seeing the dentist regularly.
Okay. Anything else you can think of? And if you can't, you can just say you can't.
The only other thing I can think of off the top of my head is just ensuring she were up to date with vaccinations.
Okay, good. And what vaccines would you be discussing with her?
So for her, I'd make sure she'd had a Tdap at least once in her adult life, and then just a tetanus booster every 10 years, and an annual flu vaccine.
Any other vaccine you'd be talking to her about?
I don't believe so.
It, Not even with the pandemic we're having?
Oh, yeah, sorry. And the COVID vaccine.
I'm like, Brandy,
Sorry,
are you a non-vaxxer? Are you a non-vaxxer? No, I'm kidding. I'm kidding. All
absolutely
right.
not.
So she's 52. Is there seriously? So you covered the Tdap, you covered her the flu. You're going to talk to her about COVID, maybe even the COVID booster if she's been vaccinated, etc. And then what? There's one other vaccine that I'm thinking of.
Hmm. The shingles vaccine?
Yeah, exactly. So the Shingrix is the one that's most effective. Do you know at what age it's recommended that you can actually start giving it?
I believe 50.
Okay. Yep, right. So let's say this patient had had her hysterectomy done, let's say 10 years ago, and let's say it was not only for abnormal bleeding, so she had some adenomyosis, leiomyomas, but she did actually have a history of SIN2-3 for which she had a leap when she was 39 years of age. Would that change your pap smears?
It would. So I would continue PAP screening until it had been 25 years since her treatment for CIN2 or 3.
And would you do a cytology alone or co-testing?
Cytology alone. If
And
she didn't
how
have.
often would you do that? Yep, how often would you do that?
I believe it would still be every 3 years if we were doing cytology alone.
That's what my understanding is. Good. All right, so now you've done all that. Now you're going to counsel her about what her options are for her vasomotor symptoms. Let's assume all of her labs come back just fine low. Let's say her FSH is, 42. TSH is normal. Her lipid panel's fine. She's not obese. She's normal weight, so you're not worried about any significant cardiovascular risk factors. So what can you offer her?
So first, with every patient, I would discuss just lifestyle modifications that could improve her symptoms. So keeping her living areas cool, dressing in layers, avoiding triggers like spicy foods. I would assess how severely her symptoms were affecting her quality of life, and I would tell her that if they weren't too bothersome, they didn't necessarily require treatment because it's not dangerous if left untreated, but that if her symptoms were affecting her quality of life, there were certainly treatment options available. And then I would discuss both non-hormonal and hormonal treatment options with her.
Oh, okay. So let's say she said to you, "No, these are pretty bad. I sometimes sweat so badly during the day. I take a change of clothes to work with me. I'm not sleeping well. I wake up at night with the bed soaked." What are you going to tell her? She wants treatment. So what are you going to do?
So I would tell her that the most effective treatment for her hot flashes would be hormone replacement therapy. Since she did not have a uterus, that would be just estrogen replacement alone. There is a chart that I usually print out for patients and go over with them exactly what the risks are of hormone replacement therapy, for her, just the estrogen alone. And I would again review that that would be the most effective treatment option. If she were not willing to tolerate the risks of hormone replacement therapy, even though they're quite low, I would then go over non-hormonal treatment options, notably SSRIs, SNRIs, or gabapentin.
Okay. So what would you counsel her are the risks of estrogen therapy alone?
So I would say there is an increased risk. The most concerning one would be an increased risk of venous thromboembolism, so DVT and PE. I would tell her that the risks, it's not significantly elevated. It's on the order of 5 to 10 additional cases per 1,000 women over 5 years of use, which isn't a huge number, but obviously, those they can have severe sequelae when it does happen. And then I would also talk to her about the increased risk of breast cancer.
With just estrogen?
I believe so, yes.
And what would you say that risk was?
I would say it would be on the order of less than 5 additional cases in every 5 years.
Alrighty. So what could you do to help negate that VTE risk?
I could provide her with transdermal instead of oral estrogen.
Okay, and why would transdermal be less likely to cause a VTE?
It avoids the first pass effect in the liver.
Okay, and how does that cause you to get less VTEs?
I know that that's the reason. I don't know the details, so I would have to look that up.
And that's okay. That's a great way. I'm just going to jump out of examiner mode. That's a great way to do it. So it's okay to say, I'm not exactly sure of that mechanism of action. I would have to look that up, but I do know that's why we do provide it. Okay. And actually, the reason is when estrogen goes through the liver first, it actually that's where the coagulation factors are made. So you just get an increase of coagulation factors being made. So yeah, with transdermal, we can take it down to basically no higher than placebo. All right, let's say she said, nope, my sister had breast cancer. I'm terrified of estrogen, but I really need some help. What are you going to tell me how you're going to talk to her about the pros and cons of the other non-hormonal pharmacologic options?
So I would again review with her that these are not typically or not expected to be as effective as hormone replacement therapy. I would also ask her if she had any, history of mood symptoms or anything like that, because often if patients do, then you could be treating her mood symptoms and her hormone replacement therapy or her vasomotor symptoms with the same thing. And a typical one that I usually use would be Effexor, and so I would offer that to her.
Okay, all right, good. How soon should she see some improvement
So the
with
relief
the
with
effector?
so it's shorter than you would expect. You have to wait much longer for relief from mood symptoms with antidepressants, but I believe it's a shorter time period for the vasomotor symptoms, perhaps within a week or so.
Okay, good. Let's say she said, nope, I'm miserable. I'll take that estrogen patch. She's 52. Is there any point in time that you would recommend she discontinue it?
Discontinue the estrogen patch.
Mm-hmm.
I would recommend that she stay on it for a couple of years, but if I saw her, and I would follow her up, a month, every month or so until her symptoms were well controlled and we found the correct dose for her. And then I would follow her up at annual exams and just reassess her willingness to stay on the patch. And I would tell her that the official recommendation is the lowest effective dose for the shortest period of time, but usually people would require at least a few years of treatment, and we could reassess at her annual visits whether she was ready to try going off of the patch for some time and seeing how her symptoms were.
Okay, great. Yeah. So where do you get that little that chart that you hand off that you hand out? I think that sounds great to be able to give patients something to take home and actually look over.
It's on Up to Date under the hormone replacement therapy section, and it just has
Okay.
benefits in both estrogen alone and estrogen and progesterone. And it's not geared towards patients, but I go over it with them kind of line by line so they know exactly what the risks are and what the numbers are.
Yeah, because they definitely tend to overestimate some of the risks. Now, the WHI study actually with the Premarin only arm, it never showed an increased risk of breast cancer. That was with the estrogen progestin group. There are other observational studies that show maybe after 10 or 15 years of usage, you may start to see an increased risk of breast cancer. But what's reassuring for our patients who've had a hysterectomy for at least the first 8 years, if not longer, the WHI almost showed a statistically significant decrease of breast cancer. So we can tell them that there appears to be no increased risk of breast cancer with 8 years or less of estrogen use. All
Okay.
right, so that's with that, but with progesterone, you definitely do. And you're right, VTE is the other biggie. You did a very nice job going through the wellness exam. The pap smear, what you said about that was perfect of when you would stop it if she indeed has SIN2-3. We talked about the colonoscopy. Everybody's supposed to get it now starting at age 45. Oh, the one last thing, and then I'm going to jump to the next person is with regards to screening, ACOG wants us at every annual exam, no matter how young or old the person is, to screen for intimate partner violence, depression, because depression's the other big one. They want us to update family history at every annual exam looking for hereditary cancer syndrome. So every annual exam, we should at least update family history, any new ovarian, breast, colon, and uterine cancer. And then you went through update their vaccines and substance abuse, just to check on, smoking, drugs, alcohol, that kind of stuff. So that's on everybody. Intimate partner violence, depression, update family history for hereditary cancer syndrome, screen for substance abuse, and screen for if they're up to date on their vaccines. So good. Sorry we
Thank you.
didn't have your case list, but that was a good review. Thank you, Brandy.
Thank you.
So let's see what else we have here. Hey, Nasiri. You're still muted on your end, Nasir. You need to unmute yourself. Nasiri, you're muted on your end. You go up to where your little orange arrow is and unmute the microphone. All right, well, maybe we can just come back later. I don't know how come. Let's see. All right, so if that's really all that's testing in, oh wait, here's some more. Let's get Christina. Hey, Christina, you're muted on your end.
Hey, how are
There
you?
you
I'm
go.
actually in December. I don't
Hey,
know if I'm jumping the queue.
hey, that's okay. Nobody else was I was getting ready to say for the December people next. So now where are you? Where is everybody? When did you turn in your case list?
You know what? I haven't had a chance, so I apologize. So you can make up a case. I'm gonna put my hand up and say I'm so
Okay.
sorry.
I was like, no, it's okay. I was like, oh my gosh, everybody I'm calling
No, no,
on, I
no.
can't even find a case list out of. All right. All right. So let's see here. What am I gonna want to do for you? Let me
And I'm super
try to
nervous.
think of.
Yeah, I'm sure
Okay.
everybody is,
Oh,
but
yeah, yeah, absolutely. All right. So let's do, um, I guess let's do an OB. Let's say a 26-year-old G1 P0 comes in at term with a history of she's been leaking fluid for the past 12 hours. You examine her, you confirm she's ruptured membranes. So you're going to go, she's just starting to have some uterine contractions. So you're going to go ahead and induce her. Let's say she's 39 and 2. Um, so you go ahead, you get her induced, and her GBS is negative, and then she has maybe about 4 hours down the road, she has her temperature is increased to 39 degrees. Tell me how you're going to evaluate that and how you're going to treat it.
So in terms of my evaluation, I would be considering several different things. Choriomyelitis, it could be possible VTE related to like a DVT or a pulmonary embolism. I would assess fetal status to see if there was any fetal tachycardia. I would assess if there was any changes in the amniotic fluid, if it appeared greenish or purulent. I would assess for any fundal tenderness. And then in terms of treatment, I would gear my treatment depending on what I find.
Okay, so in addition to it could possibly be intraamniotic infection or chorio, you're going to check a VTE. Could it be any other infectious etiologies?
Yes, it could be upper respiratory tract infection. It could be COVID, given that we're in a pandemic right now. It could be a kidney,
Mhm.
so it could be like pyelonephritis. It could be a GI infection. It could be a cystitis. If she had an epidural and she had a Foley catheter in, that's a possibility. So those sort of would be my main differentials.
Okay, all right, good. So anyway, so let's say her COVID test was negative and she was a good patient. She's been vaccinated, that she also had received her influenza vaccine, and you just didn't have any suspicions of that because she truly didn't have any upper respiratory symptoms. Her UA was negative on admission. There's no CVA tenderness. So you're working more with that it's an intraamniotic infection. Tell me how you're going to treat that.
So I would first of all give her some acetaminophen to decrease her temperature. In terms of antibiotic treatment, I would start her on, if she had no allergies, I would start her on clindamycin, 900 milligrams IVQ8, and gentamicin. In my hospital, we use the 5 milligrams per kilogram Q24 dosage.
Okay, so you give Clinda and Gent?
Yes. I'm sorry.
Okay,
I take that back. Ampicillin and gentamicin. I apologize. Not clindamycin. Ampicillin 2 grams IVQ6.
okay, okay, all right. So you're going to start her on AMP and Gent. What organisms most commonly cause intraamniotic infection?
So it can be polymicrobial, but some of the infectious agents could be like rabies strep. It could be ureaplasma. It could be um, I'm sorry, I can't remember the other ones, but it's a polymicrobial infection.
Okay. With regards to chorioamnionitis, what are the fetal risks?
So fetal risk would be immediate risks such as fetal tachycardia. It can possibly lead to other changes in fetal tracing. Inadequate treatment could lead to fetal infection and also fetal sepsis. Um, I'm not sure if there is a sort of a long-term sequelae, but there is potentially that it could lead to long-term uh, sort of fetal compromise also if it's inadequately treated.
Okay, so let's say this patient, when she came in, this is her first baby, her cervix was not, oh, I don't know, let's say the Bishop score was less than 6, you're inducing her, she's got this fever, she has a pretty prolonged induction, and then she has a vaginal delivery, and surprise, surprise, you have an atonic uterus. So tell me how you're going to manage that.
Okay, so I would immediately start bimanual massage. I would inform my nurse that I'm having uterine acne. I would ensure that we have already started Pitocin, and we can bolus that. In addition to that, I would ensure that the patient had a second IV, large bore IV line in place. I would then, my first uterotonic that I use, because it's very easy to get to, is misoprostol, 1000 microgram rectally, and I would give that to the patient. I would continue doing bimanual massage. Barring that the patient does not have any contraindications, I would then give her methergin, 0.25 milligrams IM, and I would continue doing bimanual massage. I also forgot to mention that while we put the IV line in, I would have sent a set of labs on her, so CBC, PT, fibrinogen. If she does not have a type in screen and cross-match, I would have cross-match 2 units in case she required blood transfusion.
Okay, good. What about the antibiotics? So now she's had this vaginal delivery. Are you going to continue antibiotics?
So for vaginal delivery, we do not have to. We can stop it after, but if the patient appeared very ill and she continued to have fever, then I think it would be reasonable to continue till she was, at least give her 1 extra dose after delivery.
Okay, one of the things that she did end up having was an atonic uterus. And we know one of the things that increases the risk for that, of course, is intraamniotic infection. What are some other things that would increase the risk for an atonic uterus?
So a prolonged labor, including like a long induction, so long use of Pitocin, prolonged second stage of labor. In addition to that, use of magnesium sulfate for preeclampsia or for neuro-fetal protection. In addition to that, in multifetal gestation, if she had polyhydramnios, if she had any uterine leiomyomas, for example, that would preclude the uterus from contracting down, um, would be some of the concerns for uterine acne.
Okay, great, great, great. All right, good. I think you did a great job and you covered everything very nicely. There was a new committee, well, it's not new, it's August of 2017 that talks about the intrapartum management of intraamniotic infection. It's one of those ACOG committee opinions. One of the things that they did say, you said, I'm not sure if there's any long-term complications. I had just been reviewing this the other day, and this was something I don't think I was actually
Is
aware
it
of. I
cerebral
think about
palsy?
the short, yeah, I
Yeah,
think
I
more
was
about
reticent to
the,
say that. Yeah, but I read that too some time
I
ago.
know. Yeah, I think about more the short-term stuff, the neonatal
Hmm.
pneumonia, meningitis, sepsis, death. Okay, that makes sense to me. But then I'm just going to read this for the benefit of everybody else. It says intraamniotic infection can be associated with long-term complications for the infant, such as bronchopulmonary dysplasia and cerebral palsy, potentially due to the effect of inflammation alone. A recent meta-analysis of 15 studies found a significantly higher relative risk of cerebral palsy among primarily premature infants exposed to either histologic chorio or clinical chorio. It is nonetheless too important to acknowledge that the overall absolute risk of cerebral palsy remains quite low, approximately 2 to 1,000 live births. And again, they were looking at this in preterm infants anyway, like preterm with chorio. So I guess they were saying they saw a little bit more cerebral palsy in the preterm with chorio versus preterm
Hmm.
alone. But anyway,
Okay.
that was news to me. So very good. All right, any questions for me?
So I use the terminology chorioamnionitis, and I know now we are using the intraamniotic infection. So would that be
It they
incorrect?
No, they say it can be used interchangeably,
Yeah.
but when this committee opinion, here's the first line of this committee opinion. Intraamniotic infection, also known as chorioamnionitis. So they do jump back and forth. Either one is fine to use. But
Okay.
because they were calling it that, I'm trying to play the good professor and call it what ACOG said in 2017.
Mhm. Okay.
All right. Okay, that's certainly not something to lose sleep over. Now, if you don't know how to deliver a shoulder dystocia, that would be losing sleep, but not saying chorio versus intraamniotic. Okay, you did a great job.
Okay. Oh, thank
Okay,
you.
thanks. Bethany, let's get you. Maybe hopefully you've got your case up.
Yes,
Yep,
I'm
I see
here.
a case. Yes, and you're here. You're here twice. Okay. What? Yay. All right, what case list would you like to do?
Let's pick something off Office.
Okay, let's do it. When do you test?
November
Where are
2nd.
you? Where is files? Now, don't tell me nobody's going to have their stuff here. Let me just, isn't that weird? Let me go back and see if I can get your office. Isn't, look at that. Doesn't have a preview we can show you. Okay. Maybe, wait, maybe here's something. There we go. Computers are idiotic. All right, so do you have a particular one or you want me just pick something?
Just pick one if you don't mind. Thank you.
All right, let me just take a quick look here. All right, let's do patient number 20. She has a lot of issues here. So you have a 26-year-old G0P0 who presented with abnormal bleeding, irregular menstruation. She was obese, but she also had hypertension. So had her hypertension been diagnosed and was it being treated by someone else or did you make that diagnosis?
She was previously diagnosed and currently being treated by her family medicine practitioner.
Okay, and what medication was she on? I
She
mean,
was
I
on
see it, but I just want.
lisinopril HCTZ.
Okay, so if you, what's your concern with her being on that blood pressure medication?
With the thiazide diuretic component, um, I believe there can be wasting of a particular electrolyte, but I would have to look that up to verify.
Okay, what type of what category is lisinopril in?
ACE inhibitor.
Okay, what's the problem with that in, I know you
Oh,
put a
yes. You could
yeah,
be
so what's the
concerned
problem with this? Right, go ahead.
if she were to become pregnant, you may be concerned for fetal defects like renal agenesis.
Yeah, and what percentage of pregnancies are unintended?
I would have to look up the exact number, but I do believe more than half.
Absolutely. So I think the primary care doctor didn't do a very good job of picking that as her antihypertensive. So that's my 2 cents worth. If somebody who's young, I know she's obese and has irregular cycles, but she's a G0P0. I would, what do you think would have been a better choice for her for an antihypertensive?
Like a beta blocker or a calcium channel blocker.
Yep, absolutely. I agree. All right, now abnormal uterine bleeding. So tell me, when somebody comes in with that complaint, tell me what you're going to ask her about history-wise, and then tell me the labs you're going to do and why.
Sure. So I start with a good menstrual history. So I like to find out if she's having regular menstrual cycles or are they irregular or completely unpredictable? How heavy is the bleeding with each menstrual cycle? Is it interfering with her life? Is she having any pelvic pain associated with the abnormal bleeding? And has she ever been worked up for this in the past? Is she taking any medications currently to assist with this, or has she ever taken any medications in the past? Yes, that would be my starting point.
Okay, great. So in this case, was she having infrequent menses? Is that what it was?
Infrequent, and when she did have menses, they were quite heavy.
Okay, all right. So then tell me what labs you did.
So for her, I started off with doing a TSH, prolactin, LH, and FSH for her, and estrogen.
Okay. And tell me, I understand what you were looking for with the TSH. I get what you're looking for with the prolactin. Tell me how the LH, FSH, estradiol, what are you looking for with those?
Since she was skipping cycles so frequently, I was basically checking to make sure that her hormones were at baseline, and that she was not having a dwindling or a decreasing estrogen level.
Thinking that she could have what?
Like premature ovarian failure.
Perfect. That's what I was hoping you'd say. Okay, good. All right. So now then you also checked a testosterone that was elevated. So with her A1C and her lipid panel, did you get all of that at one time, or did you wait until you made your diagnosis of PCOS and then order that?
For this particular patient, because I had a high suspicion for possible PCOS, I did go ahead and order the testosterone lipid panel and A1C at the same time as the TSH, prolactin, estrogen, and FSH.
Okay, good. Well, and she was obese anyway, so getting her A1C and her lipids would be a good idea. All right, so then tell me what's the Rotterdam criteria and how you actually made the diagnosis of PCOS.
Yes, so the Rotterdam criteria are criterion for diagnosing polycystic ovarian syndrome, and you're required to have 2 out of the 3 to be diagnosed. The first would be some sign of irregular menses or oligomenorrhea. The second would be either lab values or clinical findings of elevated testosterone. So elevated testosterone levels or possibly like cystic acne or hair growth in atypical places like facial hair growth. And the third would be an ultrasound showing an abnormal appearance of the ovaries, such as multiple cysts on the ovary or a large volume size.
Okay, so for her, she did not have a lot of androgenic skin effects, I'm guessing. She didn't have severe hirsutism, acne, anything like that.
She did not.
Okay, all right. So tell me how you and her came to the decision that a levonorgestrel IUD would be a good treatment for her bleeding issues.
Yes. So we talked about different methods for helping to regulate her cycles and decreasing the bleeding when she had cycles. And we talked that birth control pills would likely not be the best choice for her due to the fact that she has the high blood pressures requiring medications for control. So then we talked about the IUD. She also was seeking birth control as well, since she was sexually active and not using a contraceptive method. And so the IUD was the perfect decision for us for helping to decrease her bleeding with cycles, but also offer her effective contraception.
Good deal. Because what's the problem of hypertension in OCPs? So let's just say she had her blood pressure was controlled with medications. You know how we break those oh, there's like it's like a what is it, like a C or a D or a 3 or a 4, what we say like with medical comorbidities and different forms of contraception. Do you know what OCPs would be in the face of hypertension while controlled on meds?
I think it also depends slightly on your age. I would have to double check, but I want to say it's a 2 or a 3, but I would have to verify that.
It's a 3, and then it goes up to a 4 if you're older or your blood pressure's like higher. But I think I'm pretty sure that's what it is. So yeah, so that means don't put her on estrogen containing OCPs unless there's absolutely nothing else you can give because they feel the risks outweigh the benefits. So you obviously could have put her on a progestin only, but this was perfect. You're protecting her endometrium. She can stay on her medications. Now tell me how you counseled her about why weight loss is so important.
So I counseled her that polycystic ovarian syndrome and weight gain and hormones were very interrelated, and that sometimes even losing just 5 to 7% of our body weight over a series of time can help to not only decrease our body weight, but it can help with cycle regulation and with bleeding irregularities. I actually offered this patient a nutrition referral, but she did decline it. But typically, that is something I offer my PCOS patients. And so we did talk about diet and exercise via calorie restriction and increased activity. And we also talked about psychosocial stress, which was a big factor for her and ways of helping to reduce that as well.
Okay, excellent. So when would you consider giving somebody with PCOS metformin?
I typically consider metformin for my PCOS patients, in particularly if they're attempting fertility or if they're having infertility concerns.
Okay, does the A1C make any difference?
Yes, it does. If it's pre-diabetic or diabetic, that's when I'm more prone to, that's when I usually give metformin.
Okay. Let me see if there's anything else I want to ask you. I don't think so. I think you did a great job on that. Oh, the one thing, oh, I know, I wanted to compliment you on how you discussed the weight loss because I can totally see as obesity continues to increase in our country and negatively impact our patients' health in so many ways, and there's a lot of OB and gynecologic factors that obesity does. It's really important that we are able to tell the examiners we do more than say, well, you just need to eat less and exercise more, and then you see them back in a week. But we really do non-judgmental counseling. We educate them about the health risks of obesity and then what we can offer them to try to help them achieve a healthier lifestyle. So I love the fact that you offered nutritionist, you addressed some of the other issues discussed, diet and healthy diet and exercise, etc. So good job. All right, any questions for me?
No, thank you so much.
Okay, thank you. All right, so let's see. Aviv, let me get. All right, Aviv, you're muted on your end. I'm gonna pull up the case list. And let's see. Oh, are you kidding me? All right, so Aviv. All right, I don't know why you can't unmute yourself, but on your end it shows you are muted. All right, let me try to find somebody else.
Hello?
Hey, who's talking now?
This is Aviv.
Yep, okay, finally you came through. How are you?
I'm good, thank you. How are you?
Fine. Let's get your case list pulled up. All right, so what case list would you like to do?
So there is a case on my GYN list. I would appreciate if we
Okay,
can go through that one.
good.
It's
And are you
case
a generalist?
I'm a generalist.
Okay, good. So tell me which case you'd like me to go to.
That would be case number 9, please.
Alrighty. And that's the other thing too, you guys. If any of you have a case that you're like, I just want to go over it, please feel free to bring those up. All right, so go ahead and present this patient to us.
Okay, so this patient is a 20-year-old G1P0. She was 7 weeks by LMP, was presented to the ED with right lower quadrant pain. She was found to have beta HCG, which was very high, it was 26,000. And there is a typo here, so that's one of the things, but that's okay. And her ultrasound showed that she has a right tubal ectopic. There was cardiac activity on it, and she was counseled, and she was recommended diagnostic laparoscopy and potentially salpingectomy. In that case, there was a delay with going to the operating room, and while waiting in the holding area, she ruptured. She became tachycardic, and by the time I got her to the operating room, she already had hemoperitoneum of about 1.5 liters. And after I did the diagnostic laparoscopy, I identified the ectopic on her right tube, and I performed salpingectomy.
Okay, so let's go back to the how large was this mass on ultrasound? I know there was cardiac activity, but do you recall how large the mass was?
It was about 4 centimeters, if I remember correctly.
Okay, but yeah, that HCG of 26,000,
Mm-hmm.
I don't think I've ever seen an ectopic with that high. I mean, I don't know if you can get, well, that had heart activity. I'm like, I don't know if you can get a molar pregnancy in a tube or a partial mole. You know, I'm trying to think, can you get a partial mole and it be an ectopic? Anyway, so when she came in, she has acute pelvic pain. You documented this ectopic. You see cardiac activity. You're waiting to take her for an OR to open up. That's called real life. You know, the ORs are full, so you're waiting for it. But at that initial ultrasound, was there free fluid in the peritoneal cavity?
No, so initially there was no free fluid, but then with the delay, I was going to assess her, in the meantime, and she complained of severe pain and she was tachycardic. So at that
Okay.
time, I performed a fast scan, and I noted free fluid, which seemed significant. At that time, I pretty much knew that
Okay.
it ruptured.
So
And
what
then
would you say was the time sequence between when she came into the emergency room, you said, all right, we need to take you to surgery, and when she ruptured? Well, how much time would you say that was?
it was about between 2 to 3 hours.
Okay, well, that's not that big of a deal. And I don't mean to say it. She ruptured, but she basically came in with an ectopic, right?
Correct.
That just
Yeah.
didn't meet the criteria for medical management. She came in stable. It wasn't ruptured. It's just the HCG was really high. It was a big mass and there's heart activity. So you're like, you're not a candidate for methotrexate therapy. We'll take you
Correct.
to
That
the
was that.
OR and do a
Yeah.
salpingectomy. That's
Mhm.
exactly right. So
Yeah.
unfortunately, but fortunately for her, it occurred while she was at the hospital, while you were waiting for an OR room to open up, and the time interval was maybe 2 to 3 hours. She actually ruptured while you were waiting and had such a significant rupture and blood loss that she became hypovolemic and tachycardic. Okay, so then once that happened, how how long till you were able to get into an OR?
Once that happened, she was on the table in about 20 minutes to half hour.
Okay, all right. And so then you were able to suction out about 1.5 liters of blood. How much blood did you have to transfuse her with?
She got transfused 2 units. She was stabilized
Okay.
with IV fluids and 2 units.
How did you make this diagnosis of DIC?
Her fibrinogen was very low, and based on that, I mean, I think the bleeding once the tube was out was she was not bleeding afterwards, so I had no concern on that. But
So
I sent
what
the
else
coax.
goes low?
Mhm.
Go ahead. I'm sorry. Go ahead.
Yeah, so when I saw this large amount of hemoperineum, I sent intra-op stat labs that included CBC and coags, and the fibrinogen was very low. Her H&H dropped, her hemoglobin was below 7, and her INR was elevated.
All right. What with DIC, what else typically drops? Besides the
Um,
fibrinogen?
you mean other than the
Like
hemoglobin hematocrit?
platelets? Do platelets drop? Does anything else drop?
So her hemoglobin and hematocrit dropped significantly from the time before she got into the OR. I'm trying to think what else.
Well, I guess because here's the big question that I've seen brought up before. With DIC, how do you know it's really DIC or if it's truly just a normal depletion of blood coagulation products because she bled so much? Do you know what I mean? Like when somebody has when we institute massive transfusion protocol and we add in fresh frozen plasma, platelets, and blood, it's because we know the patient is bleeding so much. And in addition to losing red cells, they're losing all their coagulation factors with the blood. Do you see what I'm saying?
Yeah, yeah. I
So,
thought, yeah,
so
I
I
thought you were asking
go
if
ahead.
I tested for any, because I did not send any other tests.
Yeah, because don't fibrin split products go up to, I mean, it's been a while since I've looked at DIC, but I remember reading before a thing, and it might have been one of the practice bulletins about DIC, and the big question being, how do you show it's DIC versus just dilution of the coagulation factors? Because really, why would she have DIC?
I would think just because of the significant blood loss and just
But does that
consuming
really trigger?
consuming her coagulation factors.
Right, but that if is that the pathologic process of DIC that can occur with like an amniotic fluid embolus, an IUFD, you know, um, almost like a HELP syndrome, or was she truly just losing a lot of blood and you just had to put back blood and blood factors? Because DIC, what's actually happening? You're getting all these little micro clots all over, right? And you're
Mhm.
using up all your clotting factors because you're doing these micro clots throughout. Was she really doing that or was she just bleeding out? I guess that's my big question. Or am I not making sense?
No, you are. My thought process was that she was losing significant amount of blood, and in that process, um, a lot of her coagulation factors were already used. So she had dysfunctional coagulation going forward to stop the bleeding.
Okay. Okay. So you gave her a blood transfusion. Did you do anything else? Did you
She
give her
received
fresh frozen
IV
plasma?
flu. I'm sorry?
Did you give her fresh frozen plasma or did you just give her blood?
Um, she got massive transfusion, I believe. So she got FFP and platelet as well.
Okay, all right. So you did institute mass transfusion protocol. All right.
Yeah,
So
because it
yeah,
was
so
not
that would
initial.
go ahead.
Yeah, initially she got the 2 units, and once the labs were back, and there was the thought about the DIC, then she got the rest of the blood products.
But she didn't have any further bleeding, the good news was, right? She wasn't bleeding from like her IV sites or any of those things that we can sometimes see with the DIC where the platelets crash and all the
Correct. Yeah,
coagulation
thankfully,
factors. Right,
yeah,
right.
thankfully she was not. Mhm.
Okay, because there's a difference of bleeding and depletion of blood factors versus a consumptive coagulopathy. And the reason that your factors are low and then you start bleeding is because you're having all this little clotting occur intravascularly. I'm not sure if you're following where I'm trying to go. I mean, it's a fine point. Um,
Mhm.
but anyway, that's where I'm just was trying to go. Was this really DIC or just massive hemorrhage?
Um,
But so
I think it,
what was your question about this patient? Why are you
so.
concerned about this?
So I was questioned with someone else that I worked on my list. I was questioned about the fact that I did laparoscopy on a patient that had a massive bleeding and was tachycardic, um, because I know in other places she might have got laparotomy.
Okay. In I guess my feeling was in your hands, you could get in with the scope quicker, suction everything out. You knew it wasn't like you didn't know what was going on. You know what I mean?
Yes,
It's not like she had um, a surgical abdomen full of blood and you didn't know if the spleen was ruptured, if it was some other sort of a large vessel tear. You knew what was causing the bleeding. And the worst case that would have happened is you put in the scope you couldn't see and you would have opened her.
right. Yeah, my thought was I know how to handle it. I don't think I compromise her by going laparoscopically. I don't think I lose time over that.
I
She
think
can
you
be
might have
stabilized.
saved time actually.
She can be
But
stabilized with IV fluids with the blood, and I can, end it up quickly and have her with like shorter recovery time. She's a 20-year-old, and I don't want to,
yeah,
open her up and risk her with the recovery. And um, so I was
yeah.
just trying to.
If she was in shock and it was like they almost were doing CPR and her blood pressure was 40 over palpable, you know what I mean? That might have been a different story. You wouldn't have done the scope then, but this was somebody that you were right there. It happened. You got her back, and I didn't even actually question that
Okay, so I feel better about that
route.
now because,
Yeah,
yeah,
I
I
didn't
was
even
not sure
I
if
thought
that.
your whole thing was I thought your whole thing was the DIC. I'm like, okay, well, why are you asking me about this? But anyway, so no, I think that was excellent management.
Okay, so because I know in some practices people will say if there's any question about the patient's stability, then you would do a laparotomy, and I don't practice this way. It would take a lot in order for me to do laparotomy, because I really think that laparoscopically I can do it quickly enough and just
Yeah.
solve the
So that and
problem.
that's the thing that you feel expert enough with the laparoscopy, you felt you could get there quicker, suction the peritoneum, get that tube and over or get that tube out where the pregnancy is. But had this patient come in with just a belly full of blood by ambulance, you would have never done a laparoscopy. because you wouldn't even,
Okay.
it would have been general surgery opening her up anyway.
Yeah.
Do you know what I mean? And then they would have consulted you if it was some hemorrhagic ovarian cyst or an ectopic. But if she came in with her abdomen full of blood and nobody knew what was going on, then yes, that'd be a laparotomy.
Okay. Yeah. All right. So you answered my
Okay.
question, and I'll go
Okay,
through this
good.
DIC. Okay.
Yeah, double check the DIC thing. Okay, sounds good. Thanks. All right. Okay, I know we're at time, but let's see. Let's see if we can get one more in here. Let's see if we can get Ashley. Let's see. All right. Now it says you're self-muted, Ashley. I guess you put your hand down. All right. So now your hand's back up. Can you unmute? Click to mute. Okay.
There you go. Can you hear me?
Okay, are you there? Oh my gosh. Everybody's taking for, yeah, I can finally hear you. How are
I
you?
know. I think that it's like being really sensitive. It muted me and unmuted me like 3 times. My name's Ashley. They have
I
a
know.
misspelling.
I know. I started. I said called you Ashley, and then I go Ashy. All right. I figured it probably was. All right. Let's
I'm testing
see
in
here. Let's
December
pull
too,
you
so
up.
if there's someone in November,
That's okay.
okay.
That's all right. Let's just do it. What we're going over anyway. So, what case list would you like to do?
Let's do office, I guess.
All right. All right. I was just writing your name. Okay, dokie.
Any case is fine.
All right. All right. I'm going to actually do this one. Patient number 4, 20-year-old comes in for contraceptive counseling. She's currently using OCPs, but she desires a LARC, and she had recent negative STI testing. So tell me, when you educated her on her various options for LARC, yeah, just tell me how you counsel them about their options and the pros and cons.
Well, first I start, the general history. So if she has any medical issues that would preclude her from certain contraceptive options, but assuming she's healthy, like this patient, I typically start with the LARCs, the options that work the best. So the Nexplanon or the various types of IUDs. And then I go to options that aren't as reliable, like birth control pills, the patch, the NuvaRing, the Depo shot. And then the next tier down being like condoms, male condoms, female condoms, calendar method, that kind of thing. And with each of them, I talk about their method of action and their effectiveness and what the patient would need to do in order to use them and how to place them or
Okay.
remove them or how often, how long they work, that kind of thing.
Okay, so let's just go back to, she comes in, she's on OCPs. What do you counsel? Let's say, I'm assuming she's on an estrogen containing OCP. So what would you counsel her about some of the benefits of being on an estrogen containing OCP?
Benefits of being on an estrogen-containing OCP include cycle regulation, improved dysmenorrhea. If she has any family history for, let's say, ovarian cancer or something like that, we do know that it decreases her risk of that. Can also improve acne. So those would be the benefits versus a progesterone only, depending on what she had. May cause more irregular cycles if she has like the implant, the Nexplanon, or maybe amenorrhea with certain IUDs. And if that is something that she didn't want, that would maybe be a downside for her.
Okay, all right. With regards to then the levonorgestrel IUD, you already told me a little bit how you're going to counsel her menses wise, and the menses being irregular with both the etonogestrel implant and the levonorgestrel IUD, that hopefully she'll get lighter and lighter menses and then get amenorrhea. But what would be contraindications to a levonorgestrel IUD?
A contraindication would be a current pregnancy that she wanted to keep, current PID, or concern for active cervicitis or STI. Also, if they
Okay.
had a uterine anomaly that I couldn't place the levonorgestrel or any IUD, that would be a contraindication as well.
Okay, so you would go ahead and you insert the levonorgestrel IUD. How do you counsel her about the risks of expulsion and perforation?
I discussed that at the time of placement, there is a small risk of perforation, but given the way that the device, the inserter device is, that it's quite small, less than 1%. And if there's any concern, we can do an ultrasound to confirm placement. Expulsion for her is also quite unusual if she was immediately postpartum or immediately post like DNC, then the expulsion rate is higher, especially with the levonorgestrel versus the copper.
Yeah, what is it immediate postpartum,
For the
the
levonorgestrel,
expulsion rate?
I believe it's almost 20%.
Yep, that's what I remember reading, even 25%. I'm kind of like, well, so why do we do it? But I guess 75% of them stay. I guess that's why. All right,
Yeah.
so then and then in general, what's the percentage of somebody who's just a non-pregnant woman getting a levonorgestrel IUD? I mean, you say it's small, but I mean, is it 1%? Is it 0.001%? What's the
For expulsion,
likelihood
I'd
she
say
could
less than
expel?
5, but I would need to look up an exact number for that.
Mhm. I've always read like it's about 2%, somewhere right in that range. Okay, so now you do the levonorgestrel IUD, and you said patient satisfied with IUD at return visits. So when are you going to see her back?
I usually see my patients back around 4 to 6 weeks later. If they're sexually active, I suggest that they can check the strings themselves. And if they're having any pain with intercourse or something, then we can also trim the strings. So I usually have them come back and do a pelvic exam and make sure that they're not having any abnormal pain, and check on their bleeding, and go from there.
Okay, so let's say she came back and she said she's doing fine. You put in the speculum, you don't see any strings. Now what's your differential diagnosis and how are you going to evaluate it?
So if I don't see any strings, then I will use a pap brush and try to see if they're just sort of stuck into the cervical os. So I'll try that. And if I can't tease them out, then I will do an ultrasound and evaluate, is it displaced? Has it been, has it perforated, or was it expelled? Although with an expulsion, typically patients will describe like having heavier bleeding than they're used to. So that would be a little bit less on my differential unless she described having a lot of abnormal bleeding.
Okay, and so let's say you do an ultrasound, you're unable to tease the string out, but it's a perfect fundal placement. So now what are you going to tell her?
I tell her that it's in the correct place, it's working, since it's properly placed, but when it is time to remove it, we may either do it in the office if we can grab it with like an IUD hook, or she potentially could need a hysteroscopy either in the office, if she could tolerate it, or in the operating room to remove it. Or she has the option of trying to remove it now if that's bothersome to her and replacing it.
Okay, so let's say you do an ultrasound and the uterus is empty. So now what are you going to tell her?
I would tell her there's a risk that it's perforated and is in the abdomen, and we will get an X-ray to see if we can see that, or that it's been expelled. And then while we're
Okay,
working her up, I would tell her to use a backup birth control.
okay, so prior to going and getting that X-ray, anything else you're going to do?
Pregnancy test. Yeah.
All right, great. Yeah, so I was reading, there was good job. So yeah, I was reading on, there was a practice bulletin on managing complications of the LARCs. And what they talked about was when they come back, if the uterus is empty, okay, doesn't matter if it's in her abdomen or if she flushed it down the toilet. The bottom line is she is not protected pregnancy-wise. So we have no idea how long she's not been protected pregnancy-wise. So
Right.
definitely get a pregnancy test before you send her to get an x-ray so we're not radiating a new little IUP. But the
Mhm.
other thing they suggest, and would not have thought of this, was if they had intercourse within the past 48 or 72 hours, it's reasonable to offer them emergency contraception. And now we can do ULA up to 5 days because who knows for how long they've not been protected birth control wise. And for me, that was like a little light bulb, like, oh, aha, duh. Yeah, you know what I mean? If they're using it for contraception, that is something that we should consider also. So good. Any questions for me? And you did a great job on the contraindications, pregnancy. Did you say active breast cancer?
I didn't, but that was one I was missing.
But yeah, so
I said
then
yeah.
we talked about PID within the last 3 months, active cervicitis, and again, any type of uterine anomalies that would preclude that. And then I was trying to say, oh, the OCPs, the only other thing, of course, would be if she was someone who had recurrent ovarian cysts, being on combination OCPs are going to help with that, where the levonorgestrel IUD wouldn't help with OCPs. But other than that, I think you did, I mean, you came up with everything else, the regular menses, decrease acne, decrease ovarian cancer, less dysmenorrhea, etc. So good. All right,
Thank you
guys.
so much.
Well, it's 9:04. Thank you so much. Anyway, we'll call it a night and we'll leave it there. And I'll be back with you guys, I think, in November. So good luck for those of you who are going to be testing in November because I won't be talking to you. All right, sounds good. Bye-bye.